We're slightly, typically we're out of order here because when I'm presenting lateral access to the thoracic pathology, primarily disc herniations is what we're going to deal with as neurosurgeons and orthopedic surgeons. Typically, you would go after someone presents the more traditional lateral interbody fusion that where you learn a lot of the basics, and that's really where where your workhorse is, and then ultimately you'll end up after you've done your first 100 of the lumbar spine, you'll consider going up into the thoracic spine. So. But what I'm going to do is give a little bit more than just lateral access. I'm going to talk about thoracic disc herniations and approaching them in less invasive fashion. Before doing so, here's my disclosures, and I don't believe any of them have any significant relevance here. I am from the University of Pittsburgh, and you're kind of hearing this name a lot. I've got a couple partners here, David Okonkwo, Kojo Hamilton, that are also out there. And but prior to getting to Pittsburgh, you should know that I'm from Boston, actually, and same as Juan Uribe, which is why we have the same accent. So given that we're here in Seattle, I thought it was only appropriate to enjoy this one more time. Rod, all right. Thank you, Rod, again for having me here. This is pretty much on any given evening. This is what you'll see from Dr. Osquian. But let's see here. Who would like to speak up? Here's a. Can you see that? Okay, is that showing? I'm not presenting a case in the sense that this is a 49-year-old woman. We'll get to these actually in their cases specifically, but. Sir, right there, second row, fourth guy in. We're making eye contact. What's your name? What is it? Sohom? I'm not saying it properly, am I? Okay. So just talk to me about what you're looking at here. Tell me what you see.
Sure, so I'm seeing a sagittal.
Microphone.
On the left, there's a sagittal T2 weighted MRI of the thoracic spine that shows a disc bulge. Not sure what level because I can't really figure it out. And then on the right, we have an axial T1 weighted MR.
Okay, but what are some of the characteristics of this disc herniation? In other words, is it?
It looks central,
okay.
And there's a loss of disc hydration at that level. There aren't any modic changes.
Okay. Are there any other things as you're looking at this central herniation, you're thinking, as surgeons, we're often thinking, well, what is it that I'm going to need to do for this patient, do or not do? And regarding the symptoms themselves, what do you think this patient may be presenting with? What type of symptoms would develop from a patient that comes in with
I would
central
worry
herniation?
about myelopathy, certainly if they had a sensory level or if they were hyperreflexic.
Okay. All right. Any other imaging that you think would be pertinent or important to obtain as you're trying to figure out the problem or what to do for this patient?
I mean, certainly a CT would be helpful.
CT. What do you want a CT for?
Well, if that's like a bony osteophyte or if that's just a soft disc.
All right. Yeah, you're heading down the right direction. Again, I'm just throwing some stuff up there to see where we start off, because this isn't often an area where people have particular interest. I know that there's not a whole lot of neurosurgeons that say, my specialty is in the thoracic spine, and mine isn't either, nor was it. But the problem is that people don't like to do these, right? Because the morbidity is particularly high when you're operating in the thoracic spine, and when you go ahead and do one, all of a sudden you become the guru. People say, "Oh, that's the guy I'm going to send all my thoracic stuff to," and then they start to come in, and you end up getting quite a little practice, despite the fact that you didn't necessarily want it. But so that's good. You're thinking a lot of things in the right way. How about let's move over to the gentleman to your left. What's your name? Corey Herman. Where are you from, Corey? Florida. With Uribe or who? University of Florida. Oh, the real Florida. Okay. So, what are we looking at here? Okay. Okay. So, but the point of putting these things up here is soft disc herniations, calcified lesions. Are they paramedian? Are they central? These are the things that you start thinking about considering as you're trying to come up with plan and again, symptoms, right? Here's another one, very similar, to the last one off to the side. Or perimedian lesion, is it calcified? These are things that your mind should immediately start kind of putting together as you get your gestalt, as you start trying to figure out what's the right thing to do for this patient. So can someone tell me the incidence? What do you think the incidence of thoracic disc herniations? Is this a common thing? Is this something that's incredibly rare? What do you think?
Compared to lumbar, I should say around 10%.
10% of disc herniations. So 10% are symptomatic or
Asymptomatic.
asymptomatic?
Most of them are asymptomatic, maybe 1%.
Okay, so you say most are asymptomatic, but maybe 1% of disc herniations are symptomatic. That's actually pretty darn close. So symptomatic incidence is less than 1%, about half of 1% of all disc herniations per year occur in the thoracic spine. The majority of them are asymptomatic, and in incidental findings, we're seen in up to 17% of the population that had MRIs. So they're typically identified between the third and the fifth decade of life. They tend to be multiple, and of course they're found very commonly in patients that have cervical and lumbar herniations, because that's why they're getting the MRIs, right? So you find these asymptomatic lesions. Luckily, most are found below T7 in the lower thoracic spine, and we'll talk why that is, what I say luckily about that. But the natural history of these asymptomatic disc herniations is actually quite favorable. They rarely change over time and rarely become symptomatic. And in a study by Brown, he showed that 77% of these patients that presented without myelopathy, so without weakness, without spasticity, patients that presented with pain or radiculopathy, these patients actually, the majority of them, almost 80%, had resolution of their symptoms without surgical intervention. So the symptoms, oftentimes when patients come and see you, they have this protracted chorus as to, they've been having pain or they've been having whatever symptoms they've been having for quite an extended period of time by the time they get to you. And that the reason is because they're often very nonspecific. But the symptoms that they do come to you with are localized pain, right? They say someone's stabbing them right there in the back, and they point very specifically to right where their problem is. Myelopathy, of course, and radiculopathy, with the most common symptoms being pain. That's in 3/4 of the patients, followed by sensory disturbance, followed by myelopathy in nearly half of patients, and then 1/4 having bowel and bladder dysfunction. So imaging, given the high prevalence of disc herniations on imaging, it's incredibly important. And this isn't just with thoracic herniations, of course, this is with anything, right? Any type of pathology that we're looking at. Very, very important to correlate our imaging with the patient's clinical presentation. And I can't stress that enough, because I'll have patients that come in and they'll have had an MRI for whatever reason, and then they'll find this disc herniation in the thoracic spine, and all of a sudden, they go home and they do their research and they're fixated on the fact that they've got spinal cord compression, totally asymptomatic, as the majority are. But now you're dealing with this patient and trying to explain to them, they've got this rock pushing on their cord, they're asymptomatic. The likelihood that they're going to be injured from something that you do is a lot higher than something that asymptomatic lesion is doing. So something to keep in mind. So MRI is the most commonly form of imaging for diagnosis. It allows you to look at the spinal cord itself, evaluate for myelomalacia. It also, of course, allows you to evaluate the amount of compression on the cord, as well as the exiting nerve roots. And importantly, and this is, I can't stress enough, the most important thing here, if you take home something, is that you're able to count. So if you have a long sagittal image that shows you from the sacrum up, that allows you to count from the bottom up. And I'll again comment on how important that is, and why. And as we talked about from the start, Sohom, that correctly indicated that CT scans are particularly helpful with these patients, because you want to determine if these are calcified, because if you have a calcified lesion, that could completely change your treatment course, and that's something that's very, very important to know. So just like real estate, right? The most important rule in real estate is location, 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 right? With our surgery here, it's preparation, preparation, preparation. And if you're prepared if you spend your time preoperatively determining what potential complications can arise, what situations can occur as you're moving through, you're going to be prepared to be able to handle that situation. For example, Dr. Okonkwo, you'll note here in this image, this here is Dr. Okonkwo. And this here is some unlucky poor soul, myself, who decided that we're going to go on a nice little trip together. And we thought we were prepared. We were definitely underprepared. as you can see here, if you don't prepare properly, you can get yourself into situations that are can be unappealing. And in certain instances, for example, things can happen if you are underprepared. But luckily, David's always a step ahead of me. And what he did is he actually arranged to have one hanging by the side of the boat to make sure that there's always someone to drop his legs on to make sure that he's staying safe. And yes, that was me. So preparation, be prepared. So treatment. Conservative therapy is very often the treatment course for patients with thoracic disc herniation. Certainly, if they're coming to you and they're asymptomatic, it was an incidental finding. But even in patients that come in, as long as they don't have myelopathy, these patients can often do well with conservative treatment options. In fact, when patients come in and they come in with pain, they have radiculopathy. If this is a quality of life issue, from my perspective, the burden is on them to convince me that they need surgery, right? Whereas if a patient comes in and they have myelopathy, they have significant cord compression, they have long tract signs, they're having gait imbalance, then the burden is on me to explain to them why they need surgery, right? So it's a very, very different dynamic depending on how they're presenting to you. Such surgical considerations. So there is no standard algorithm that exists out there that says if a patient comes in and they have this type of herniation, then this is what you do. Every patient is individualized, every case is individualized. It depends on a variety of factors, including the level of the herniation, its relationship to things such as the diaphragm, to the aorta, or other major vessels, whether or not it's a medial herniation or a lateral herniation, where it is in relation to the nerve roots and the cord itself. Is it extending out the foramen? Is there an interdural component? Is it calcified? Are there numerous herniations, and are they segmental, or is there actually a skip lesion where you've got something occurring at T6-7 and then another one down at T9-10? The patient's premorbid status. Again, if there's significant pulmonary dysfunction in this patient, these are things that you need to consider as you're discussing or trying to determine whether or not surgery is going to take place, and if it is, what kind of surgery. And this is also incredibly important, is the experience and the familiarity of the surgeon with the approach, right? Again, this is not something that is exceedingly common, that we all are going through, and we're doing 80 or 100 of these cases during our residency. This is something that that oftentimes what you'll do is you'll get familiar with a particular approach, and that's what's happened with me in the couple approaches that I'm going to discuss at length are the two that I'm most familiar with. But again, strategic planning, very, very important. You want to make sure that you've spent a lot of time before you even get to the operating room planning out what you're going to do. So let's briefly discuss on some of the options, some of the approaches here. The anterior approach, there's advantages to having an anterior approach. Number one, it gives you direct access, right? You're able to see the pathology. This does require often not too many people, I don't think, are adept at getting into the thoracic or into the thoracic cavity without the assistance of a thoracic surgeon, co-surgeon. So that can be difficult at times. And personally, I'm a big. Do you have a question? I'm sorry. No. They're actually. I think that was right before the end. I think they were, determining which finger to put the ring on, but. So, just for fun though. The advantage is direct visual access. This is oftentimes recommended for central disc herniations, calcified disc herniations where you're not going to rely upon feel, and you're going to be able to, you want and need to be able to see the pathology itself. But the disadvantages, right, this is an extensive procedure. There is, especially if you're down at the thoracolumbar junction, you're going to have issues with your diaphragm. Again, you're going to require a co-surgeon. We can't handle our own complications oftentimes if there's issues, if you have a thoracic duct injury, if you have a major vascular injury. You're required to call someone else in to help you repair your own problem, and that's incredibly disgruntling for neurosurgeons and orthopedic surgeons. And of course, the potential pulmonary and mediastinal complications that were noted. So The risks of pulmonary complications is it's significantly higher in the elderly, in smokers, in those, as we said, with pre-existing pulmonary cardiac disease, and certainly this leads to contraindications to surgery, right, or to an anterior surgery. Patients that have had fused pleural space, whether it was iatrogenic or whether it was something that occurred on their own, the inability to tolerate single lung ventilation. And again, we'll talk about certain procedures do not require single lung ventilation, as in one of the more modern approaches, including the MIS lateral access procedure, and we'll talk about that. Relative contraindications, chest trauma, previous thoracotomy. The lateral approach, and this is where we'll talk a little bit more. There's a couple different approaches that you can take here. The transcostovertebral approach, the costotransversectomy, which is probably something that more people than not are familiar with if you do have to do this procedure and you're doing it in an environment where the surgeon is comfortable performing this procedure. This is, I think, the most common approach that's performed, certainly at my training at UVA. Lateral parascapular extrapleural approach, and this is for higher up in the thoracic spine, and then lower down is the lateral extracavitary approach, which is actually when you take it's a pretty significant extensive resection where you're actually taking the rib, you're taking the transverse process, you're taking the pedicle. So it's a big deal. It's a big deal. And remember, oftentimes we're treating a disc herniation, right? But disc herniation in the thoracic spine are different animals than they are in the lumbar spine. So totally different approach for the similar pathology. So posterior approach, this is less extensive procedure, and this is where familiar. This is where we are all comfortable as spine surgeons approaching the spine, right, from the back. So it's got that, and it's to the benefit. The transpedicular approach, very commonly employed. It enables straightforward access to the lateral aspect of the spinal canal, and nicely, unless you're doing several levels in continuity, it oftentimes does not create instability. You can take the pedicle in the thoracic spine. You've got these nice stabilizing structures, right? The ribs that are coming around and helping to provide that stability. So it doesn't necessarily need, if you take the pedicle in the thoracic spine, doesn't mean you actually have to perform any supplementary instrumentation. And then the transfacet, which is pedicle sparing, going slightly more lateral. The important thing to note here is that you do not have anterior visualization, right? So if you have a central calcified disc and you're approaching it from either a transpedicular or a transfacet approach, you're going by feel. You're not able to see what the pathology itself, and you can get into some danger there. So minimally invasive, and this is kind of why I was recruited, and why oftentimes a lot of these patients end up in my lap, is because they like the idea of minimally invasive surgery. Now, minimally invasive can mean a variety of things. What I often try to tell people is what minimally invasive does not mean is that you're getting a different surgery, right? What it does mean is I'm going to perform that surgery, or I'm going to get to the problem where the surgery is differently. But once I get to where the problem is, surgery is the same, right? It's not a shortcut. It's not a back door. It's simply less intrusion or less invasion to the surrounding natural structures. And this is something that you have to keep in mind. Oftentimes I'll tell people it's the same procedure, it's a different retractor. And you know, the idea out there, patients will come and say, well, I want this tiny little incision, and that's minimally invasive, right? But to me, you can have an incision, you know, from chin to chest. I'm sorry, from you know, your chin through down your sternum. That can still be a minimally invasive procedure. Skin's going to heal, right? Scars are one thing, but and again, that's where the patient's perspective comes in, and you have to educate them as to what MIS really is. But the bottom line is it's the amount of destruction or injury to the surrounding soft tissues. There's been several studies out there. I'm not going to talk a lot about thoracoscopy since I don't do it. The first thoracic disc herniation I did, I actually brought in a thoracic surgeon and had him come in there, and we spent 5-6 hours trying to pull out this disc. And I thought, well, this is there's going to be a learning curve here that I'm just not particularly interested in, and because there's other ways, and that's what we'll talk about. But in the literature, there is several examples of thoracoscopic approaches in comparison to open approaches, and there's significant reduction in a variety of blood loss, narcotic use, hospital length, but significantly, and this is not an insignificant thing, is that the incidence of post thoracotomy intercostal neuralgia is significant, occurring in approximately 50% of patients that have open thoracotomies, as opposed to less than 20, about 16% of patients that have had the less invasive procedure. So this is something to think about. And I'll tell you that when patients come back and they are just moaning and groaning about this new neuralgia that they have, you think it was worse than the disc herniation. They can be just miserable. So complications and the pitfalls. Very, very important to understand what you're getting into. The morbidity associated with thoracic disc surgery in comparison to lumbar is completely different. But the number one cause, right? The number one cause of during surgery that is the most common complication, right, is actually misidentifying the level. So I would say count and count and count again, and always count in the same way before surgery as you do at the time of surgery. So my friend here, once again, tell me how you would count. How would you determine that you're going to be at the appropriate level? What are some of the methods that you can use? Live fluoro. What does that mean? You just take a shot and you
Count from the sacrum up.
Count from the sacrum up. So you're starting. What if you're imaging? Do you use fluoro preoperatively to determine what level the problem is at, the pathology?
No, we have an MRI and presumably show you where your thoracic disc
Okay.
herniation is. And
Oftentimes it doesn't, though, right? I mean, how many times do you see patients come to clinic and they have a thoracic MRI, right? Do you count the ribs? Do you start from the top down? The bottom line is, however you're going to do it the exact same way. Do it the exact same way in the operating room as you are preoperatively.
So I've watched indirect wrong level thoracic surgery about 4 times in my career. And what Rod did when he came here about 7 or 8 years ago is that we do fiducials. We have a radiologist now place a fiducial every time. He pretty much zeroed out that complication. And Rod goes one step further. He actually gets a myelogram after the fiducial is placed to double check it really carefully. But it's completely changed the game for us. It's been a huge.
Yeah, and that's one way. I've heard people have done it, and if you don't have, if it's not calcified, it may be something that's another way to do it. But the bottom line is the most important thing you can do at the start of your surgery is make sure that you're going to be at the proper level, right? You got to be at the appropriate level, because it's an arduous task performing the surgery itself, and the last thing you want to do is find out you're at the wrong level after you spent a couple hours in the OR. Charlie.
The other thing that I do is, very often patients who have thoracic disc herniations often have anterior osteophytes, so those are very often visible, and so I just check for individual characteristics of the osteophytes that are either above or below the area of interest, and use that as a reference point.
Yeah, that's a great point, Paul.
One thing I'd emphasize: always have plain radiographs of the lumbar and thoracic spine, because you're going to use those to get more radiographs. You need to make sure you know if there's transitional vertebrae, how many lumbar vertebrae they have. I like to go by AP x-rays and looking at the ribs. If I can clearly identify the 12th rib and the first lumbar spine to me is the first vertebrae without a rib, and then just count up from there, because you can usually see the ribs pretty well on x-rays.
Yeah, absolutely. You got to have x-rays, because that's what you're looking at in the operating room, right? You're using x-rays, so you have to know, is there a sacralized lumbar spine? You have to know how many ribs there are, but without a doubt, x-rays are...
And that's true for even lumbar discs. We had a root cause analysis after wrong level surgery in a very obese patient by someone else. That was what the radiologist demanded, that we always have plain radiographs so that they have something to look against when we're looking at intraoperative ones. But I find it very helpful. And if you're up high in the thoracic spine, then count from the first rib, because you can usually differentiate C7 and T1, and then identify the first rib and then count down.
Yeah, and every institution, oftentimes you'll learn the way that that group does it, and these are all, great ways and markers, and not necessarily one is better than the other. Use them all. The bottom line is get the right level. Charlie or David.
The other thing is especially if I'm doing a posterior approach, once I've done a laminectomy, I'll use intra-op ultrasound, and that is an incredible tool to verify the disc and its imaging appearance and compression of the spinal cord. You can see it very obviously.
But by the time you're doing that, in order to do that, you've done bony work.
Right, you've done bony work, but at least you're verifying again that you're at the right level.
Right.
Before you've attempted to, violate the disc space.
David.
Yeah, what I was going to add is, however you intend to count this, you also have to make sure that your pre-op MRI allows for the same thing. So if the scout for the pre-op MRI, if they're counting from C2 down, okay, and they're not showing you that they're also at the exact same level counting from the sacrum up. So this is something that must be done pre-op in clinic to ensure that you have an MRI that allows you to count consistent with however you're going to count in the operating room. And I got burned by this once, which we fortunately caught it before she went to sleep, but it delayed the surgery because we had to send her down and get her another MRI when I realized that we could only count, that they were only telling me the level by counting down from C2, but they were not telling me the level by counting up from the sacrum.
Right. You can see the importance, right? Pretty much every faculty member in the back of the room has piped in on this slide. It's important, and this is where everyone gets burned. So keep that in mind as we're moving through. So other issues to be aware. So we talked, at length, identify the level intraoperatively. Make sure you're doing it in the same manner preoperatively as you are intraoperatively. Postoperative instability is rare due to the stabilizing rib complex. CSF leaks, although rare, has been reported in up to 15% of cases. Pulmonary complications we talked about, pleural tears. I mean, this isn't counted. 13% was what was in the literature, but I think that's significantly higher than that. I think that's underreported. Infections, intercostal neuralgia, although it is not uncommon following these approaches, but it's dramatically decreased with less invasive procedures. And I'll go through the process myself, but one thing to keep of note is that, when you're using these less invasive techniques, oftentimes you're kind of cranking some form of device open, some retractor system open. And what you don't want to do, or what kind of your initial impression is to give it a crank, and so you can get those ribs to open up as wide as possible. That's not the goal of minimally invasive surgery, right? The goal is to be open as much as you absolutely need to be. So I'll open it until I see the ribs move, at which point I'll release it one click, so that I'm taking some of the pressure off of that neurovascular bundle, and we'll talk more about that. But again, preparation, understanding, knowing what you're getting into. For example, once again, if you get a drink like this, right, you're going to do something like this. Yeah. But this isn't the real travesty, right? What is, though? Who wears these? That's the problem. These are chubbies. That's not a bathing suit. That's a pair of shorts, and this is what he wears to the OR. So it's very odd. Okay, and I gotta also preface this talk with a few of my videos are not working, so I apologize for that. But I do have a video if someone's interested in seeing a thoracic discectomy from beginning to end. I can show you that during the lunch period. But in regards to prognosis, the one way to surely fail your boards is to respond to what the appropriate treatment for a disc herniation is with laminectomy, right? Laminectomy has given terrible outcomes. Up to 86% of cases had poor outcomes. following a laminectomy. And, this again, that's the impetus for new techniques, but also less invasive techniques. Surgical outcomes are attainable, or good surgical outcomes are attainable with modern day approaches and improvement. Oftentimes we'll see patients come in and they'll have significant symptoms. They'll have myelopathy. They'll have the typical pain. We're seeing significant improvement. This doesn't mean cure. This doesn't mean that their gait is back to normal, but it means improvement in their quality of life and their ability to function. And that can occur, in 80 to 90% of patients that present to you with symptoms of myelopathy. Almost 90% of patients that come in with, the number one symptom, which is that of pain. It is incredible to me, the patients that come in and I'll perform this operation, and how happy patients with thoracic disc herniations are after their surgery. But all it does, again, it leads to telling you how miserable they must be before surgery. And when you warn them of the potential risks involved with this with this type of surgery, imagine telling your lumbar discectomies that there is an 8 to 16% chance of a neurologic deficit when you wake up from this operation. How many discectomies would you do? Not too many, I can imagine, but people are lining up to have their thoracic discs removed despite a 8 to 16% chance of neurologic morbidity from this surgery. There's a few guys out there that have experience with all these approaches, and this is, Rick Fessler is one of them, and he's performed the procedure transpedicular fashion, transthoracic, costal transversectomy, lateral extracavitary. But interestingly, you'll say look at the numbers are relatively the same. They're not significantly different from one another as far as the morbidity associated with these procedures or complications that are associated. But look at the complications rate is about 10%. In the hands of Rick Fessler, right? One of the guys that helped come up with many of these procedures that we perform today in an MIS fashion. So keeping that in mind, again, it is the patient's job to convince you that they need surgery, right? And it's not on the first visit. It's not on the second visit. But it is when they're to you for their third, for their fourth, fifth visit, and they are miserable, begging for surgery. That's the point at which at which I'll consider taking a patient electively for thoracic disc surgery, not with myelopathy. With myelopathy, again, different story. That's my job to take care of their problem. So the two approaches that I think are of modern importance that I'm pretty good at are the transpedicular approach and the MIS lateral approach. And we'll talk a bit more about the second, given that that's really what I was assigned to talk about here. So moving through relatively quickly, these are from Bilski's paper from the Focus many years back. But again, the goal here, right, is the same. No matter what approach you're taking, get the herniation out, minimize the manipulation of the cord and the neural structures. So you performing the transpedicular approach. You basically want to drop your dilators or your retractor or whatever system you're utilizing along the pedicle at the level below the disc herniation, right? Because you can see here on this sagittal that the disc is going to be sitting in front of the superior aspect of that pedicle. This is a paper that is Praveen here. Praveen basically, so this was when I did my fellowship in 2007 with Praveen, and you can see here, this is a paper we wrote up on the mini-open transpedicular thoracic discectomy, surgical technique and assessment. Every time we dropped the tube and no one else had reported it, we're writing it up. So this is why you have this report. You'll have a few others, but excuse the simple animation here. And it's not specifically you're dropping it straight down, but the bottom line again, you're dropping serial dilators down. You're landing at the front. Unfortunately, this is one of the videos that did not work, but you can see the resection of the bone that you're going to be taking in the transpedicular approach. You're really kind of staying lateral. And what I'll typically do is I always like to see normal before I even approach the abnormal, and I'm quite comfortable looking at the lateral edge of the dura. So I'll always do a little hemi-lam, expose the dura, work my way out lateral, and then I start taking the pedicle. And you got to remember here that you're constrained with tubular system. You're constrained not only your visualization, but your ability to manipulate your instruments, right, by how lateral you go here. So the more lateral you take that TP, the more it is you're going to be able to wand over your tube, wand over your retractor, and be able to get underneath and more anterior or central, I should say. This video does not work. Let's get some of the cases that we kind of talked about, but here's the presentation. So 49-year-old gentleman, left-sided radicular pain. So radicular pain, no myelopathy, normal examination. The pain fully resolves for progressively shorter periods of time after serial injections. So, we're on our 6th visit. The patient comes back. We're over a year out from the patient initially presenting, saying, "I'm absolutely miserable," right? And this is the pathology. So we talked about some of the things that we're thinking about. Let's go back to who was it that I showed this case to at the start? So what are you thinking now? So we've just learned a little bit, or maybe you already knew all this. What are you thinking of doing for this patient? 14 months into it, progressive, severe pain. Pain got better, in fact, fully resolved the first several injections, but unfortunately, it's persistent. No myelopathy, despite there being some abutting of the cord. No myelopathy.
Guess if his pain was no longer treatable via conservative measures, this is paracentral to the posterior approach.
So posterior, so laminectomy? No, right.
Transpedicular.
Transpedicular. You can see here it's right up against the lateral edge of the pedicle. That seems like a reasonable option. Anybody else? Anybody agree or disagree? Anybody disagree would do something different? Okay, and that is what we did. And we dropped a tube down. Again, I wish you could see the videos here, but you can see where our retractor is, dropping down, sitting on top at the superior aspect of the lamina at the level below, drilled off the lamina. But what's important to note, and what you would see in this video, is that you don't just drill down the pedicle, right? But you actually drill into the dorsal aspect of the vertebral body. And the point being is that you never want to persuade or manipulate the disc material that's abutting the cord. You always want to move it away. You never want to pull it towards the cord. You always want to push it away from the neural structures. So what I do is I often create a small void, a centimeter or so into the vertebral body, and at which point I can then get a downbiting curette. I can create my plane there real nicely and gently, starting above or below the pathology itself, and then I'll just kind of persuade it in. And more often than not, unless it's a real calcified, adherent mass, it'll plop right into there, and you can pull it out quite nicely away. And you can see I actually left a small portion of the lateral pedicle. Not that it was on purpose, but I was able to see it relatively quickly early on, and similar can be done for paramedian soft discs. You can see post-op, the CSF is now surrounding the cord. Symptoms dramatically improved. And this was the write-up that we had performed, showing that, again, the significance, right, in performing this procedure in the less invasive manner was really the blood loss, right? I mean, there really wasn't dramatic differences in how patients did post-operatively, especially if you went out, 2 years out. But really the blood loss was the only significant difference between the two. So oftentimes it's do what you're good at, what you're familiar with, as long as that's the appropriate treatment strategy. Here's another one, again, removal of ossified ligamentum flavum, again, not disc herniation, but similar approach. But you can see, obviously, this was more posterior pathology, and it was removed posteriorly, but we did get a publication out of that, right, Praveen? So lateral access surgery. Juan Uribe is going to exhaustively go over the benefits of lateral access surgery, but in regards to the thoracic spine, it's less disruptive. It's small incisions. There's no rib resection required. Lung deflation is unnecessary. There's fewer pulmonary complications. Blood loss is minimal. Again, gives us that direct, familiar visualization of the pathology itself, and chest tubes are not required. And what that means is that chest tubes are not required post-operatively. Oftentimes, we will use we'll put in a red rubber catheter or something to try and minimize the pneumothorax if we're into pleural, but it's not something that's required long-term. The risks, potential complications, pleural fusions, pneumothorax, intercostal neuralgia, damage to major vascular structures, very similar risks if you were doing this as an open thoracic procedure. But again, these are not necessarily things that we can fix. As neurosurgeons, we would need help. Luckily, the majority of disc herniations occur in the lower thoracic spine. The reason I say that is because it can be very difficult to get into the upper thoracic spine laterally because the ribs get closer together. The rib heads cover more of the disc space. It's that gap, our ability to get in there and not cause pressure on that neurovascular bundle is minimized. And you have large structures, right? Large vascular structures that you'll see in a moment. The diaphragm can become a problem anytime you're around T12, L1. Interestingly, when I first started doing these, I would bring in the thoracic surgeon and I'd say, well, what do I do about the diaphragm here now? And 100% of the time, incision small. It's a linear incision. It's not mutilation of the diaphragm. It's elevation or a simple opening. And they say leave it alone. And I've yet to have a complication related to that. And if any of the other faculty would like to speak up in regards to having had a problem, it's just not something that occurs. So. The neurovascular bundle, right? That neuralgia that we talked about, it's very important to avoid excess retraction. The neurovascular bundle sits under it sits at the bottom of the rib above. So oftentimes, if you're coming down, what you want to do is find the rib below and stay on top of that. And that's something that you'll see in a moment in one of the videos here that is working. If you do need to perform an osteotomy of the rib, and I have yet to have to do this, but I think Juan does this a fair bit, is you can use a doyen, and again, the bottom line is you want to spare the neurovascular bundle. You can see here that aorta, right, that is not your friend. And higher up in the thoracic spine, it's sitting in direct access on the left side. You have to have a right-sided approach. Higher up in the thoracic spine, lower down, it starts to move itself anteriorly and central and gets out of the way, and you're more likely to be able to come in from the left side, because you do have things on the. You got to remember, again, you're dealing with the liver, you're dealing with other organs that we're not particularly adept at working with. So things to keep in mind as you're performing your surgery. The artery of Adamkiewicz, there is some variable anatomy, but the majority of them come off the left intercostal artery. This is what feeds the lumbosacral cord. So injury to the artery of Adamkiewicz can result in syndrome, anterior spinal artery syndrome, which can leave you with motor loss, bowel and bladder dysfunction, but typically spares sensory, as we know, because that's posterior. So positioning, the arm should be positioned high enough to avoid interference with the fluoro machine. And when breaking the bed, you want the break actually slightly different than if you're doing a lumbar procedure, which is, you want the break at the same place every time. With thoracic, you actually want the break below the level of the index level that you can operate at, so you can widen that intercostal space. I can't tell you enough. So the couple of guys that we worked with the other day in the lab, I can't tell you enough how important it is to spend your time. I'll spend as much time, if not more, before my incision, planning the operation with the patient on the table, positioning them properly, getting a perfect AP and a perfect lateral, because that is where you can, number one is getting the wrong level. Number two is having the patient be off, having the patient be rotated. You can end up, working straight down, but ending up in the cord or ending up in a major vessel. So very, very important. Make sure that you've got, your spinous process is right there in between your pedicles. The pedicles are symmetric. The pedicles are abutting the lateral edge of your vertebral body. I can't stress enough. So I'll throw this to spark some memory that angles are important. You can see this nice little statue here, right? That looks nice, right? If you get the wrong angle, it looks very, very different. So again, more angles. This is just all angles here. This is an important one that I think we should all recognize. What the angle, this is at the end, I'm sure you all remember, that's Malcolm Butler. I'm not sure who that guy is. I can't remember his name. Nobody really can, but yeah. All right. Count and recount. Start from the sacrum, under live fluoro, count rostally to the index level. Ensure that preop imaging also counts in the same caudal to rostral manner. And the ribs can also be used as adjunct level markers. Again, I'm repeating things here that are incredibly important. Your incision is going to run parallel with the ribs. You can see here dividing of the intercostals, showing the superior aspect of the inferior. The superior aspect of the inferior rib, obtain interpleural access along the top of that rib. The dilators are advanced in a dorsal trajectory. So basically, I'll drop my finger in once I've entered the pleural space or the pleural cavity, and I'll follow my finger along that rib, and then I'll do the same with the dilator sitting directly on my finger, staying back. The last thing you want to do is poke into the lung, right, or into any other vital structure. So I'll feel my way all the way along until I'm on the spine, at which point I'll take my imaging and confirm that I'm sitting there laterally, at the midpoint or so. And this is simply another image showing. Now obviously the entire lung doesn't get persuaded like this. The lung works around you, but starting off with your dilators, you want to make sure that you start dorsally and work your way interiorly. The retractor is then advanced, and the retractor, now if you're doing this in the lumbar spine, as Juan's going to show you, you're doing it so the retractor handles are facing towards you, so you can use that third blade to sit in front of your posterior longitudinal ligament. But here, we're not worried about that, right? In fact, we want to see our PLL. So you want to flip the handles around because you're going to use a spatula. You're going to use that third blade to protect the lung, right? These, again, what structures are you trying to protect during the surgery? And in this particular surgery, we're going to want to do the same procedure, which means you're going to remove rib head. You're going to be able, you want to see the dura, you want to see the PLL, you want to persuade that pathology away from the cord. So here you want to be able to see posteriorly. You want to protect anteriorly. So once the retractor is secured, shims can then be placed within these blades to expand that safety of your surgical corridor, expose the disc space, and protect those surrounding tissues and organs, again, primarily the lung. So now, again, I will reconfirm the level. Can't tell you enough how many times I will do this. But at this point, right, you've confirmed your level. Now it's a thoracic discectomy, whether you're looking through a tube, whether you've got a massive, shark bite incision and you're looking open, whether you're using a thoracoscopy, now you're performing a very similar procedure. Depending on the level, various portions of the rib head are required for removal. The lower down, the less rib, the higher up, more rib. But the one mistake I think everyone makes is they don't remove the rib head, or they don't remove enough of it. And I'll show you another picture in just a moment, but I begin the discectomy by coring out the center, staying away from the structures that are concerning until I can actually start seeing normal. Always find normal first. At which point you then start wedging out the vertebral bodies, and I can show that better here. So this is anterior, this is posterior, and you can see here this is vertebral body above and below, and you can see the bone being removed above and below to enable access and visualization to the posterior ligament and the dura behind it. At which point you can then persuade this, since you've cored this out first, you can now persuade the pathology away from the neural structures. Now cage, the cage must be sized, and Juan will talk a lot about this in subsidence and what all this means, but the bottom line is in the lumbar spine, oftentimes you're trying to slightly oversize to get an indirect decompression, so open up that disc space slightly, whereas in the thoracic spine, you've got some rigid structures there that are not going to allow you to do that. The bottom line is you want to get in the appropriately sized cage to minimize injury of the end plates themselves. And I'll show you a quick example of when that does occur. So here's the rib. You can see the rib overlying the T910 disc space. The rib is removed. Again, there's visualization. You can see the nerve root exiting the foramen where the pathology is. Core out the center of the disc space. Wedge off your bone above. Wedge off the bone below. There's the pathology, and you can now start persuading. This is a little, you don't want to be, again, pushing towards, you want to be pulling away. So something to keep in mind, but you can see there's an instrument there that's protecting the dura behind the PLL as you're performing this maneuver, and there's the cage placement postoperatively, and very similarly, again, showing the beginning and then each step, and finally the dura nice and freely decompressed with the pathology removed. So here's another case, 61-year-old woman, localizable mid-back pain. No radicular pain. She does have gait imbalance, she has hyperreflexia, she has clonus. So this is a lady that has myelopathy, right? So we're back to our original case here. It's a soft central disc at T910. What do you think? What do you want to do? Does this change anything that you learned, change anything that you want, what your original impression was, or what are you thinking?
As far as surgical approach.
Concerned? Or?
Yeah, let's assume, we've gone down the road of confirming this lady has a myelopathy.
Sure, so I would do a costrotransversectomy to approach that level.
Okay, that's a totally reasonable option. Other options exist, as we've discussed. Got a CT scan, right? As you suggested doing, it's not calcified, it's a soft disc. So we did a lateral approach. Was able to get our graft in there nicely. You can see the rib head removed. You can see the exposed canal, and you can see the graft having been placed. And there's the post-op MRI showing the CS signal. Similar situation. You had a calcified disc. Again, same thing. But take a look here. You can see the cage there. What do you note about that cage? Yeah, well, it's posterior. That is true. But also look at where it is into the bone, right? I mean, that was an oversized cage. This was early on in the experience where we thought, well, let's do what we do in the lumbar spine and thoracic spine, and it's oversized, and it basically, eroded into the end plate and subsided in. Not sure how useful it is at this point. And oftentimes, to be honest with you, we don't even use cages. More often than not, we don't use cages. This is the article that shows, looking at 12 patients that had this procedure, length of stay, blood loss, OR time, but 2 complications, a pleural fusion and intercostal neuralgia, right? Intercostal neuralgia, it's a big deal. Key points in closing: if surgery is indicated, posterior lateral MIS approaches are preferential for paramedian extradural soft discs. Anterior approaches are favored for centrally located calcified discs. MIS options can be safe and as equally as effective as open options, but you must be carefully evaluating its limitations based individually upon anatomic constraints and, of course, surgeon experience. Minimally invasive cannot mean minimally effective, right? You've got to get the job done, and that's the most important thing, is that every patient that goes on that table, think of them as a family member, and you want to make sure you're getting the job done. Key surgical steps need to be performed no matter how you're performing the procedure. You need to get the pathology out, and you need to do so in a way that minimizes cord manipulation and maximizes removal of the material. If anybody's interested in working with either of these clowns or myself, we have a great fellowship at Pitt. We're more than happy to have people interested, give us a call. And lastly, I'll put a plug in there for the spine section meeting. And residents, fellows, I can't tell you enough that Charlie Kuntz was a friend of all of ours and someone that was lost far too early. But there was an outpouring of a love in the form of donations when Charlie left us, and the section chose to invest that money in you. And for I hope everybody's looking forward to it, but the spine section meeting is in March of 2016, and there's going to be 30 awards for residents. So between $500 and $1,000 given out to the top 30 resident abstracts. And if you have a manuscript attached to it, you get $1,000. Same thing with John Jane. I trained at UVA, and he is my mentor, friend, father figure, and we have an award that is in his honor as well for journalistic and academic neurosurgical excellence, the Jane Award. It's a $1,500 cash award to the best resident or fellow abstract. So it's a great meeting, and I encourage you all to come and put an abstract in, because the likelihood is you're going to get an award.